Thanks, Dr. Lynn. Good morning, everyone. My name is Julie Retzky, and I'll be presenting our project looking at the impact of the timing of ACL reconstruction on the development of post-traumatic osteoarthritis using a mouse model. So it's well known that up to 60% of patients develop post-traumatic osteoarthritis, or PTOA, at an average of 10 to 25 years following ACL reconstruction. And although some studies suggest that early reconstruction may mitigate PTOA, others have found no difference in the timing of surgery and the development of arthritis. Therefore, the optimal timing of ACL reconstruction in order to mitigate PTOA has not yet been fully elucidated. And in addition, the impact of both the local and the systemic immune cells on the development of PTOA has not yet been determined. Our primary aim was to evaluate the impact of the timing of ACL reconstruction on the development of PTOA using a non-invasive or closed ACL rupture model. Our secondary aim was to evaluate the impact of the timing of reconstruction on pain-related gait behaviors, both the peripheral and central immune and inflammatory response, knee range of motion, and tendon graft to bone tunnel healing. 55 11 to 12-week-old male black 6 mice were randomized to one of three conditions: either an ACL rupture only, ACL rupture followed by immediate ACL reconstruction, or ACL rupture followed by delayed ACL reconstruction at 7 days post-injury. We also had an uninjured control group included in our analysis. Mice in the immediate and the delayed reconstruction groups were sacrificed at 28 days post-surgery, and mice in the ACL rupture only group were sacrificed at 28 days post-injury. Our primary outcome measure was a histological evaluation of osteoarthritis using the ORC scoring system. Our secondary outcome measures included evaluation of knee range of motion, analysis of local and systemic immune cells using flow cytometry, gait analysis, and quantification of bone formation at both the femoral and tibial tunnels using micro-CT. In order to rupture the ACL, our mice are anesthetized and placed prone. The knee is flexed to 90 degrees, and the ipsilateral ankle is secured with a secure ankle holder. An axial load between 5 and 20 newtons is applied to the distal tibia at a speed of 1 millimeter per second in order to rupture the ACL. Successful rupture is confirmed by a positive Lachman test. Moving on to our results, we found worse PTOA at 28 days postoperative in the delayed ACL reconstruction group compared to the immediate ACL reconstruction group. Specifically, we found higher femoral and tibial ORC scores in both the delayed reconstruction group and the ACL rupture only groups compared to the immediate reconstruction and the control group. By contrast, the immediate ACL reconstruction group had similar femoral and tibial ORC scores compared to the uninjured control group. These are just a couple representative histologic images, again demonstrating worse osteoarthritis in the delayed reconstruction and the ACL rupture only groups compared to the immediate reconstruction and uninjured control groups. Moving on to range of motion, we found that the delayed reconstruction group experienced persistent stiffness at both 14 and 28 days postoperative. And while the immediate reconstruction group initially experienced stiffness at the 14-day time point, by 28 days, they were able to regain their motion similar to that of the uninjured controls. We found no difference in pain-related gait behaviors between groups at any time point. Specifically, we found no difference in the time and swing phase, time and stance phase, stride frequency, gait symmetry, and paw area peak stance between groups at any time point. To identify the lymph node that drains the knee joint, a separate cohort of mice underwent intra-articular Evans blue dye injection. We found that the ipsilateral iliac lymph node and its associated afferent and efferent vessels retained Evans blue dye following the injection. Therefore, we used the ipsilateral iliac lymph node as a readout of the local immune response and the spleen as a readout of the systemic immune response. We found an increase in total iliac lymph node cellularity, but not spleen cellularity in both surgical cohorts compared to the ACL rupture and the control group. There was no difference in bone formation at the graft-bone interface or bone mineral density of the tibial and femoral tunnels between the immediate and delayed reconstruction groups. And these are just a couple representative micro-CT images showing bone formation at the femoral and tibial tunnels. So in conclusion, we found that immediate ACL reconstruction mitigates the development of PTOA in a murine closed ACL rupture model. The ipsilateral iliac lymph node reflects the local inflammatory environment, and chronic unresolved inflammation may lead to progressive PTOA. Although future studies aimed at elucidating the role of reconstruction timing and inflammation on the development of PTOA will allow us to better address this very common and detrimental sequelae of ACL injuries. In terms of limitations for this study, we only used male mice, and all of our surgeries were done open, as arthroscopic surgery is not possible in mice. So I'd like to thank all my co-authors for their support and guidance over the last 3